Hello, I'm Julie Blackpeart,
And I'm Lorraine Brooks.
and welcome to Health Center Dialogues, our first inaugural show. Today we're going to be discussing HIV, and we have two very special guests. I have Mr. Ryan Scanlon, who is an assistant professor at S.U.N.Y Downstate Physician Assistant Program, and he is also the director of the new HIV tract for the Physician Assistant Program. Welcome, Ryan.
Thank you for having me.
Welcome.
And our other guest is Chantel Stephen, who's an MPH candidate here in our School of Public Health. And she has a concentration in community health sciences. Did I say that right?
Yes.
Very good. Welcome to the show, Chantel.
Thank you for having
being
me.
on the show.
Well, I'd like to start out talking to you, Chantel, a little bit, because you went to Trinidad, and you're from Trinidad, am I correct?
Yes,
Okay,
I
you
was
went to
born and raised in Trinidad.
Good. So you went there and you did a dissertation and some studies with regards to the care of HIV and AIDS patients there, right? And you spent some time in, I just want to make the Queens Park Counseling Center at San Fernando General Hospital, and you were doing some outreach there. And you noticed that there were some disparities there with regards to the patients, and what problems did you see? Tell us a little bit about it.
Of course. So on my first day there, I realized that the HIV, both the HIV and the STD clinic was located far from the main hospital. So automatically I knew that patients going to the HIV and STD centers were known.
They were singled out from the rest of
Yes,
the
they were singled out. So other people coming to the hospital would know that they were going over there to get either STD treatment or HIV treatment.
Okay. Oh, I see. Okay.
So
So
how do you suppose that affected the patient? Do you think that
I definitely think that it affected them because, you know, it's a huge hospital, and just having people know that you're going over there means I have something. So automatically there's just a stigma there towards them. And possibly they might feel uncomfortable just coming back there every 3 months or so to actually get care.
right. So they also get treatment not only for HIV and AIDS there, but also for various other sexually transmitted infections. Am I correct?
Yes,
Right.
you're correct.
Right.
So the STD clinic and the HIV clinic are separate.
Okay.
The STD clinic is for HIV testing, and it's for the treatment and testing of other STDs, while the HIV clinic is specifically just for treatment services and testing. So in some cases, if an HIV patient acquires an STD, she or he will have to go over to the STD clinic to get treatment, and that in itself is another form of stigma,
Right.
because now you have to tell additional staff members about your status, or maybe just the fact that they know about your status causes them not to, want to go there.
Well, that brings me over to you, Mr. Scanlon, because I know that you work at the STAR clinic that's right here at SUNY Downstate. Do you see that patients are feeling the same way in terms of being stigmatized because they're coming to the STAR clinic, and what's the story there?
I mean, not so much. I mean, it sounds like the geographical issue that, in Trinidad, I mean, you might as well just, put a scarlet A on them and be done with it. I mean, the fortunate thing about the STAR clinic is that it is incorporated into the hospital, and the hospital on the first floor itself has about 8 or 9 clinics. So there's really no, way of knowing, there's nothing, no indicator that the STAR clinic specializes in HIV.
Oh, there's no big sign that says STAR?
It just says STAR. And, actually now, especially, we're sort of expanding our services into both Hep C treatment, BUTE programs for people that are, coming off of, IV drugs, oftentimes that have HIV and Hep C co-infection. But what's really exciting is that we're now getting a lot of HIV negative patients coming in to start PrEP, or pre-exposure prophylaxis, which is, kind of all the rage right now. And it's kind of at the forefront of HIV prevention services in major metropolitan areas, especially Brooklyn.
If I could, I'm
Go
sorry.
ahead, yeah.
If I could step back for just 1 second, because I'm interested in knowing what it is that got you interested in working with HIV patients. I mean, that's a specific population that many people don't want to deal with. What Ryan? What was it about HIV patients that piqued your interest, or that made you want to work with them?
I mean, I think it probably has a lot to do with, my age and the time in which I was brought up. I grew up in the time of AIDS. You know, it wasn't HIV then, you know, everyone just called it AIDS. And, you know, I watched people, you know, on television dying from this disease that I didn't understand. And then when I began to, you know, grow up and become a fully functional, you know, and for lack of a better word, sexual adult human being, it became that much more real. The idea that you could contract something that could theoretically be fatal. Little did I know that, you know, the medications have evolved to the point where now it's considered to be a chronic illness, even much better to have than, like, let's say, diabetes. So I guess it was almost it's always kind of been something that's fascinated me. And I mean, not sad to say, but, you know, being a gay man myself, it's very prevalent in the LGBT community. Well, mainly gay men and transgendered female.
Yeah, just for
female.
people who don't understand what that means: lesbian, bisexual, transgendered, and gay. Right? Okay.
Yeah. And, you know, I guess it was almost a way of, you know, doing something for my community, because it is something that has plagued my community for so long. Fortunately, and this is something I didn't know going back to the idea of stigma, fortunately, the stigma in the LGBT community is not what it is in the heterosexual, like, Afro-Caribbean community, which we predominantly see here. Okay. It's very different. It is, to be HIV positive as a gay man is relatively acceptable. It's not shunned. Unlike here, where people are afraid to disclose their status for fear of rejection from not just partners, but from community members, church, everybody. It's very, very problematic. Whereas in the gay community, you see not super common, but you see what we call serodiscordant partners. People in a relationship, which one positive, one negative.
Right. Okay.
Yeah. So for the listening audience, go ahead.
Exactly. No, I just wanted to clarify what that meant. That one person is HIV positive and the other one is not.
Yes. Okay. So that can bring it around to you. Where did you get your interest in
HIV?
Working with HIV patients?
So not too long ago, maybe it was 3 years ago, I mean, I've heard of HIV. I didn't know a lot of stats about it or how it affected African Americans in particular. And I landed a job at Harlem Hospital at the ID clinic.
Okay.
So the infectious disease clinic. They're working with pregnant moms and just women who had HIV. And I realized that HIV, I've always heard something negative about it, but these people seem like they're just like me. And, you know, they were going through so much. And I think to me, it was kind of, I needed to work with this population because they represented who I was. Okay. And not too long ago, I enrolled in the School of Public Health, and I was taking a class, Health Behavior and Risk Reduction, with Dr. Tracy Wilson. And she said something in class that really stood out to me. And she said, you know, when you come to grad school, you need to find a professor or whoever's doing work in what you would like to do so that you can further learn about it and, you know, become very familiar. So I kind of latched on to her because she does a lot of, yes. And, you know, from there, I just found this love interest, I call it, in working with HIV positive people. And luckily, you know, I got this chance to go to Trinidad, and I learned so much about where I was from and how HIV was really affecting my hometown.
Okay.
It's interesting, if I can go back to something you said, Ryan, a little earlier, about how HIV in the gay community is not the same, doesn't carry the same stigma, negative connotation and stigma. That I find that to be very interesting. Is it still that way? Because if you remember back, I'm a little older than you, just a tad. And back when HIV, when we called it AIDS, we didn't know what to call it actually in the beginning, and it was predominantly, or we thought it was predominantly, a disease of gay men.
Right.
Yeah. And so we've really, now that you're making that statement, I mean, we've really come
really a long way,
180 degrees,
a
right?
long way. And you said something else that was very interesting, and I know that you touch on it a little bit in your dissertation when you talk about the healthcare providers that work with the patients who have sexually transmitted infections, HIV and AIDS, that they also go through their own share of issues. Why don't you tell us a little bit about what you saw there?
For the HIV providers there, one of the doctors actually mentioned that, you know, when you're working on the wards and the higher ups or maybe the seniorities may not like you for whatever reason it is, they usually, kind of push you towards the HIV wards.
Okay.
So, and
as a punishment?
Yeah,
as a sort of
more like
demotion?
kind of like a demotion and a punishment, I would say.
So they don't look well positively for those people who are working and trying to help people. That's not seen as a positive thing there? This is in Trinidad, right?
This is in Trinidad. Okay. And I was surprised when he mentioned it, because he kind of mentioned it off the topic of, we were talking about stigma.
Okay.
And he said, I can't imagine what HIV positive people go through, because even as doctors here, they push us off. You go work in the HIV ward, kind of like, now I'm putting you there. That's where you belong. Kind of way.
But we don't have, Ryan, we don't have that kind of thing here. Actually, we have, who do we have working with HIV, AIDS, and patients that have sexually transmitted infections here in New York? What kind of practitioners do we have working? Everyone? Yeah. So we have doctors, we have physician assistants, we have nurse practitioners, and just everybody. Yeah, that's another big thing, because you mentioned that there's a severe lack of social workers to help to guide and teach people about how to prevent getting these types of diseases, right? Yes. And they're in Trinidad. But here in New York is a big difference, because there's a lot of resources here, right?
Yeah, well, I mean, I kind of also wanted to touch on, this all kind of relates, bringing it all back. What you said with regard to the way that the gay community sees this virus versus other, communities that are deeply affected by it, namely the, urban Black community, or Black and Latino communities, excuse me. You brought up a very interesting point. This was, at one point, primarily a disease of gay men. An entire generation of gay men were lost to it. Right. As a result of that, the community organized. The community organized, and there was this constant open dialogue about it, and that dialogue has continued. So when new data comes out, such as the notion that when someone is undetectable, meaning that the virus is controlled with the medications to the point where you can't find it in the blood, knowing that means that it's virtually impossible to transmit it, that is something that is widely understood and known in the gay community. That is not the case for a lot of other communities. So this new information, so all the new information is very much, because of this history of an open dialogue, we are a little bit more educated about it.
Well, that's one of the reasons why we want to have shows like this,
right? Is
so that we can open that kind of dialogue. And one of your thesis is, the name of your thesis is Breaking the Silence.
Yes.
Since I said that, would you want to tell us a little bit about
yes.
what that means to you, breaking the silence?
So breaking the silence means, to me, just talking about it, having these conversations, breaking the silence for people who are HIV positive, for people who are at risk, and talking about HIV, talking about STD, and just educating. Like you stated, in the gay community, they talked about it. They had an open dialogue, but yet in the African American community and Latinos community, it's not talked about. Specifically in Trinidad, I was assisting the doctor. He was doing a study on the prevalence of chlamydia and gonorrhea in HIV positive individuals, and one of the questions asked, do you feel like you get enough information on HIV? Do you get pamphlets where you go? And most of the answers were no. People weren't getting pamphlets maybe when they went out. The only time they were getting pamphlets were in the clinical settings.
Okay.
So what happens?
Preaching to the choir.
Right. So what happens to the people who don't access, care at the clinical settings, who kind of just, I'm not going to the doctor? What happened to those people?
So they're afraid to do that. And here, what you're talking about with the treatment, this is what they call the HEART, right? Can you explain to the audience a little bit what is HEART about, and what does this mean in terms of getting prophylaxis because our listening audience doesn't know what these big words mean. So we need to open it up a little bit for them so they understand.
Well, HEART is kind of a fun way of saying highly active antiretroviral therapy. It's basically what people have been calling the cocktail for a while, right?
The cocktail meaning a mixture of
HIV medication. Because the basic idea there, what we discovered, back in the late 90s, is that a single drug cannot keep the virus suppressed.
True.
You need a combination of the very minimum 3 drugs to keep the virus at bay.
And each cocktail is different for the individual, right?
Individual patient, correct. And what we've discovered through a variety of
HEART.
help me.
Trials.
Thank you. what we discovered is that when someone is suppressed to the point where they're undetectable, it's virtually impossible for them to transmit the virus. Now, of course, virtually impossible does not mean
that they
impossible, so you still have to be careful about these things. But at the same time, this is what kind of brought us to our new understanding of HIV treatment, which is treatment as prevention.
Right.
If we treat people, we get them suppressed, we are going to drastically reduce the amount of new infections.
Okay.
And if you don't present for treatment, you wouldn't know that you're suppressed. I mean, you wouldn't know that the medication.
You have to. It's a constant lifestyle. Once you're on HEART or whatever treatment program that you're on, but people really need to continue to go for their treatments. We don't want people to get caught up in the thought now that this is no longer a dangerous disease, because if you don't treat it properly, it can be. A lot of people are not aware that they're infected with the disease because you don't have signs and symptoms right away. It could be 10 years before they, or so, or even more, before they actually start to,
the average,
show something.
The average time between
are you infectious or contagious during that time?
The average time from becoming HIV positive to what we call AIDS, which is when your CD4 T cells, I'm sure everyone knows what T cells are. They're the white blood cells.
Yeah, sure.
When they dip below 200, that's when you're said to have AIDS. But we don't even like using AIDS anymore. We usually say late stage HIV. Okay. The average to get below 200 is about 5 to 7 years. Okay. Now, during that period, you are the longer that you are not suppressed, the more copies of the virus are in your blood, and the more copies that are in your blood, the more highly infectious you are.
Right.
Now, of note, and this is speaking about Brooklyn and not knowing, like not knowing your status, Brooklyn actually, Kings County, we lead the nation in new AIDS diagnosis. Now, not HIV, but coming to the hospital with an opportunistic infection or an infection that you have because you're so immunocompromised that you now have this horrible, horrible disease, and that's when you find out that you're HIV positive.
Right. What sort of diseases would appear in somebody that was immunocompromised?
The most common ones that you see, like the first ones that you tend to see, one is thrush. That's it's a fungal infection inside your mouth. Looks kind of like cottage cheese. Okay. There's that. There's a fungal pneumonia.
And people who are not immunocompromised generally do not get that?
Babies can, but that's pretty much it.
Okay.
Yeah, and just before you continue, for those who don't understand, immunocompromised is a person who's in a state where their immune system is very low, so that other infections have kind of easy access to your body and to make you ill and get other kinds of diseases and things like that.
So if you have a healthy immune system, just to explain, if you have a healthy immune system, some of these germs and viruses and bacteria will not affect you because your body will produce the antibodies or whatever it needs.
Still there.
It still fights, but they're at a very low level when you have an immunocompromised system.
Yes. And just, HIV is, of course, isn't the only thing that can cause immunocompromise.
Absolutely not.
People that are on chemotherapy where they're destroying all their white blood cells, they're also prone to these opportunistic infections. So it's not just an HIV thing. It's, just for the viewing audience to know.
Okay, so thrush is one. What others
are the big one, which is kind of what raised the red flags back in 1980, is pneumocystis pneumonia, which is a fungal pneumonia that normally, again, the body fights off, but once your T cells dip below 200, you can start having this pneumonia. Now, the problem with this pneumonia is that it's very difficult to get rid of, it's very difficult to diagnose. And if your body can't fight it off, you can see someone that's, relatively healthy in 23 be wiped out within a matter of days.
Right. Now, there's what's this Kaposi's sarcoma?
Right.
Kaposi sarcoma. Kaposi sarcoma, fortunately, is something that we don't see anymore.
Oh, that's wonderful. Yeah.
That was one of the major markers, too.
It used to be, yeah.
Kaposi sarcoma, it's a form of cancer, but what we now know is that it's actually caused by one of the herpes viruses. How it usually manifests is, purple lesions.
Right.
Now, this was because this was mostly seen in MSMs, or men who have sex with men, in the 80s, and they manifested as these purple lesions. But what we saw, as soon as they began taking HEART, their immune system started bouncing back. all these purple lesions started slowly being absorbed back into the body. So you don't really see Kaposi sarcoma anymore. You can see it because much like any cancer, it can spread.
Right.
And it can, so the skin lesions are one thing. They can be treated very easily with antiretroviral therapy or the HIV medicines. But if it gets into the viscera, namely like the lungs,
that's not a good scenario.
That's
and you still have patients that are struggling with that from the 90s.
Right. Go ahead,
just
Lorraine.
one other question, if either of you can answer this, just for the viewing audience. How would I know if my T cells were low? I mean, is that a routine test? If I go to my doctor and I say, and I'm not feeling so good, they probably aren't going to test my T cells, right?
Yeah, how do people get
how
tested?
Do people, can you answer that, Chantel? Or?
I think Ryan might be better able to answer those.
Ryan,
well, I mean, you have to remember that, so T cells are basically, they're white blood cells. So when you get your basic, blood work at your doctor,
they do
red blood cells, they do white blood cells. So they might notice,
complete blood count.
Yeah.
CBC, right.
They might notice that the white blood count is a little bit low, and that's when they might say, we need to break this down and see.
So if your white blood count is low,
that might say we should check this gentleman's.
I always thought, and this
CD4.
is just a purely layperson's very somewhat ignorant question, but I always thought that when your white cell count was high, that meant that you were fighting off an infection. So this is different then.
Well, that's because so when you are fighting off an infection, the white blood cells go up. Why? Because they're replicating so that they can go fight whatever pathogen is inside the body. People that have, HIV or late-stage HIV, their body doesn't have the capacity to generate that response. So you might notice that someone, let's say with pneumocystis pneumonia, they come in and they'll have a normal, or if not low, white cell count. Because their body just doesn't have the ability to mount a defense.
To mount an attack, right.
Right. So, the people that are treating this disease, we talked about different levels of healthcare providers, and I happen to know that you are the director of an HIV tract at the S.U.N.Y Downstate Physician Assistant Program. Just briefly tell us a little bit about what that is and how do people get involved in that?
As I said before, Brooklyn or Kings County, we're very unique when it comes to HIV infections. Manhattan, everywhere across the country, HIV new infections are going down. In Manhattan and Brooklyn, they're still climbing. Okay, Brooklyn is second only to Manhattan for the number of total people living with HIV, but we beat Manhattan when it comes to new infections and new diagnosis with the people that are diagnosed with HIV/AIDS. So
we call
this
that that's the incidence rate, right? When we talk about new cases.
Okay. So there's a need for it here. There's a need for people that are trained in the management of HIV care. So a grant was filed to basically educate physician assistants with a little bit more. Like I was saying, I said earlier, HIV is now considered a chronic illness. If you manage it, it's not going to kill you. Much like if you're a diabetic, if you take your drugs or you take your insulin, or if you've got high blood pressure and you take your hypertensives, you can live a long, happy, healthy, fruitful life. The difference is the education in HIV medications is very inferior to that of diabetes, hypertension, CHF, all these huge medical problems. So what we're seeing now is not only this lack of education, not only amongst PAs, but amongst MDs, NPs, nurses, what have you. We're seeing this aging community, all right? Because all these people that have HIV are now getting older. They're getting to their 50s, their 60s. In fact, I think it's by 2020, 70% of people living with HIV are going to be over the age of 50. So not only are you going to have people that are HIV infected, they're going to have all these problems that people that age have. And so you need to learn, we as clinicians need to learn drug interactions, how to manage the side effects of drugs, how to know if a patient is on certain HIV drugs, do we need to make sure that they're on something for their cholesterol as well? If so, which ones do we put them on? Which ones are safe to put them on?
So there needs to be a dialogue between people like Chantel, who's going to be a community health practitioner, who's going to be going out into the community and educating people in terms of prevention, and people like you, Ryan, and you, Julie, who are, you know, more on the front lines in a clinical setting. You're going to be more of a community type setting.
Yeah.
And it takes a village, as we say.
We'll all be working together.
Yeah.
I know here at Downstate, of course, you have to apply and be accepted into the physician assistant program here first. And I just happen to have, this is the pamphlet for the HIV track. With students, they'll apply to the program, and if they're accepted, there's a process, a screening process, right, to choose a handful of students, because they can't take that many, that have a particular special interest in treating and learning how to deal with the HIV patient. And that's a new program, and that's something that's very much needed, because there is a shortage of healthcare providers in our community who are trained here and who can go abroad and take that knowledge with them, right, to teach people about HIV and AIDS in our third world countries, and, you know, just wherever else the need happens to be.
Well,
so
we need to wrap things up
Yeah,
here, because we're down to less than a minute of time. And I want to thank both of you,
Oh, thank you.
and you, Ryan, for coming on the show. And
Thank you.
The STAR program is where you work.
Thank
you
you.
are an MPH student, and
Yes,
you're going
I
to be
am.
graduating in a
Yes,
month.
I
So
will. Super
congratulations.
excited.
right here at S.U.N.Y.
Right here at
Downstate,
Right here at
right?
S.U.N.Y.
Right here at
Downstate.
S.U.N.Y.
We'll
Downstate.
have another wonderful and illustrious person out there doing the very difficult work of helping people with this disease.
Right. Well, we encourage our listening audience to take the information that they've learned today and really to pass it on. HIV and AIDS is not a disease that should be taken lightly. Today, a lot of people think that just because we have all these wonderful medications that we shouldn't be careful as we used to, and we really must do that. So in the essence of being careful, be safe, and take care of yourself out there, right? And cover up and make sure that you see your healthcare provider and get tested for HIV and AIDS.